Good evening and welcome to this week's Airway Health Solutions conversation with Dr. Miraglia. I am your host, Lauren Gueits, and I am so super excited about tonight's topic, periodontal improvements with expansion using clear aligners. Welcome back, Dr. Miraglia. How are you?
I'm doing great. Excited to be here also. Yeah, this is a fun one.
Absolutely. So I know you've been treating patients using your expansion techniques with clear aligners, but for how many years now would you say?
I believe this is my 17th or 18th year.
Okay.
Yeah,
And can you just tell us a little bit about your expansion journey with clear aligners, just kind of an overview?
Yes. So at the beginning of it, I was taught how to do some IPR, and we were doing a mixture. There's a little bit of expand, a little bit of procline, and a little bit of IPR. But that little bit of IPR began as 0.5s, half a millimeter. So that was my journey at the very beginning, learning how to do these things, and I did them. It was about 6 months in, I just got tired and frustrated with the IPR. I didn't feel like cutting the teeth anymore. So I started to just make the arch a little wider. And so expand a little more, IPR a little less. So then what happened over many years was kind of reducing the IPR to minimum to none. And so it just meant you had to trade off somewhere. It didn't feel natural to move the front teeth further forward. It felt really natural to bring the back teeth wider because they were so collapsed in. And so one thing leads to another. As the years go by, I just work my way less and less IPR. And when you get to the point where you're doing primarily expansion, you're moving all of the teeth. It turns out the light bulb goes off and you recognize you don't need IPR. So nobody needs IPR. It's just a tool. And if you choose more expansion or uprighting of the posterior segment, you can avoid the IPR totally. It's not a necessity, it's a choice.
Wonderful. So let's dive in and address the many myths and the questions. I think like 95% of the questions revolve around these myths that you can't expand adults. You can only expand a limited amount. Expansion causes recession. You're going to move the teeth out of the buccal bone. So let's just dive right in and bust some of these myths. So why don't you go and share your screen and let's get to it, right? Proof is in the pudding.
Let's take a look. We'll take a look at the cases. We'll address a lot of that during the case presentations as we're showing stuff, and we'll talk more about it at the end just to make sure we've got it clear. But let's get the screen up here. We've got a lot of nice cases to share. And so I'll get these here. We're going to kind of rapid fire our way through some of these. And so, of course, the standard protocol is about HIPAA. We're not supposed to be recording and reusing any of these photographs. It's patient information. So it's not meant to go beyond this, tonight, obviously. So please don't record the photographs and post them everywhere. Case one, this goes back to the early days. This is Evan, and most people in the clear aligner world have seen his case because I did this in 2004, I believe. It's one of the first cases I ever treated. He might have been in the first 10 or 20 people I even got to treat. So he walked in like this, and he was a young guy, about 23 years old. And, he had significant issues with the deep bite, a cross bite, hygiene issues, the gum, you had plaque, you had calculus, you had a loss of architecture. You had a lot of stuff going on here. And when he opens a little bit, you could see the level and the shape of the teeth. This is as bad as you could get. And then, of course, there's real damage coming because at some point this is going to turn into bone loss and then tooth mobility and tooth loss. And this goes a long way to being a lot of trouble in a short order for a 23-year-old. Well, basically what we did was he got in and we put him through the scalings. Of course, he's going to start with the hygiene team. So the hygiene team took him through. At the time, it was Christy. She did an amazing job. Quadrants, scale him, empty it all, hygiene instructions. So once we got everything out of there and then he started to behave with a little bit of hygiene, then all of a sudden we turned him into aligners to do this. Now, it took 30 aligners. At the time, this is 2004, we used 30 aligners, 2 weeks each. This was 15 months. So in 15 months' time, we got this before and after. Now, 2005, this case comes to an end. To this day, he's never had a graft there. And, he wears a clear retainer every night to bed. It's a full resolution of his malocclusion. So the entire arch is shaped beautifully. The teeth connect to protect each other. The gum tissue resolves for two reasons. Number one, you have the hygiene component. Certainly the scaling, the root planing, and then the maintenance over time is much better. But the second reason, which you could flip-flop these, it doesn't matter to me who gets the most credit, but the second reason is improving the occlusion. Any person that's got a traumatic occlusion, it's going to be reflected in the gum and bone. And so the gum is first, the bone is second, but traumatic occlusion affects the teeth, the gum, the bone, the jaw joints, the muscles, the dentistry. We do a traumatic occlusion deteriorates everything ahead of schedule. So we were able to tackle basically three things. One, we corrected his occlusion. So now his occlusion is protective, not destructive. So that allows that tissue to remodel. What we have here at the end is tight, pink, stippled, shallow pocketed. His perio chart is a 1 or a 2 in all these sites. The second thing was, of course, the cleaning, the removing of it all. But the third was the hygiene. Now he takes care of it himself. So every 6 months he'll get a cleaning and, keep it nice and healthy and happy. So, this became this. So in that 15 months time, it wasn't like a light switch. It was a gradual improvement right along the time, all the way to here. No grafting done and nothing other than scaling and root planing. And the healing or the resolution of that tissue around number 23 is remarkable. And so, we started learning a lot about the clear aligners and how favorable they were to use in periodontal conditions. And then this kind of case leads to more and more treatment. And when we close this session, we're going to show you a case where we were working on someone with 2 millimeters of bone on those incisors. So stay tuned for that. This is an x-ray of before and after. Before we had calculus in between those teeth, he had, these nice little skinny roots with some bone in between, but he didn't have any bone damage yet because we caught him at 23 at the end of treatment, and years later, he's still good. Back in 2004, these teeth did receive a little IPR. I was probably doing the 0.2s around some of these teeth at the time. So he received a little bit of IPR, and to move those teeth and get him resolved was a treat. So, the years were going by, we were photographing this. There was a point in time where we showed a 10-year update, and, a lot of things improved for him. Once he got his smile back, all of a sudden he started to feel a whole lot better and things started happening for him. So there was weight loss. There was an improvement in his hygiene. He got a nice haircut. He changed his glass style. Like all of a sudden, he was feeling great. He went from kind of shy and, hidden to all of a sudden, just outgoing and social and happy. And so unhappy to happy, unhealthy to healthy, a smile can transform a patient. So we give him a healthy bite, a beautiful smile, a healthy mouth, and now, he's invested in taking good care of it. So it went a long way to improve his periodontal concern. Up to this day, 2004 to now, you do the math, how old is he? And he's never had a graft there. Knowing the time that's passed, I don't believe that 23 will ever get a graft. I believe that his teeth will go all the way to 95. And all he needs now, because the occlusion is there, he doesn't have the traumatic occlusion in place. If he just comes in every 6 months for a nice cleaning with a good hygienist and does, a normal or what we would consider average amount of maintenance at home, a reasonable diet, you put those three together, since the occlusion's there, he should really have these teeth when he's 100 years old and have no difficulty with that.
And one of the questions was about the vertical changes in the vertical dimension. And if you go back, you can really see how
take a look at that real quick.
Yeah, you see his lower teeth.
It's
really unbelievable.
Yeah. So the change in the vertical is important. What happens here is he's overclosed. And so a lot of the time when you're looking at the lower anterior crowding with a deep bite, the posterior teeth have lingual inclination. So hopefully my hands are in the frame. If the lower teeth have lingual inclination, usually the upper do also, because they kind of meet. And we call it that empty smile. Those buccal corridors are wide open, the dark corridors, all that stuff. But the teeth are collapsed in. Now when the lower teeth get their uprighting, they're basically rising. And so as the lower teeth are tipped up, they're elevating slightly. That's actually called relative extrusion, because you're just uprighting or tipping, but the occlusal surface is coming up higher. Now the lower teeth are getting uprighting, but so are the upper teeth. When the upper teeth are angled like this and you're doing that, you're uprighting those. What happens in the back is the bottom teeth come up, the top teeth, and what you get is they meet sooner. So when you upright the entire posterior segment and they then touch sooner, because now they're closer together, when they touch sooner, it takes away the deep bite. You have two pathways to correct a deep bite. One is posterior uprighting. That's a simple pathway. The other is anterior intrusion. But most of the time the patient is overclosed. So anterior intrusion doesn't help overclosed. That's not a correction in the cause category. So I prefer to correct a deep bite by posterior uprighting. And that's what you're going to see case after case after case.
Wonderful. Thank you.
Number two, yes. So we meet another nice young lady, probably about 36, 37 years old, but has every bit of a malocclusion, crowding, deep bite. And of course, there's a fair amount of occlusal trauma here, and it shows up very nicely on the right side. So here we have someone who is young at about 36 years old with not only crowding, there's a little bit of that buccal crossbite going on here. Those upper lingual cusps on the premolars are outside of the lower arch. So when she closes here, it delivers a lot of horizontal load. Basically, if the upper teeth are outside of the lower arch, what happens is there can be no vertical load on these teeth. So all the decades that these teeth are being used, you have this horizontal force. And if there's, this is on her right side. So if there's horizontal force on the teeth, there's a bending pressure. That bending pressure is going to collapse the entire area into this region we basically call the CEJ, but you're going to get recession and abfraction. Now, this recession occurs in the absence of plaque bacteria. So this patient is meticulous. There's no plaque and bacteria, and this is before cleaning. This is at the presentation where we just take photos. So you have someone who's got great plaque control, but recession. This recession is like 99.9% occlusal trauma. And then, of course, the abfraction, which is pretty much 99.9% occlusal trauma. So we could fill it in, we could do composite. There's nothing wrong with those things, but that's treating the symptom. And it doesn't make it bad. Those are good procedures to fill in those grooves. We do that too. But we can also treat the cause by fixing the bite. And so what we do here for her is we use aligners. And this took 24 aligners. This was a 12-month pathway, but 24 aligners, basically 2 weeks each. We correct the occlusion and it delivers an improvement in the gum tissue. We get a little bit of resolution and a different shape of that gum tissue in line. And next thing you know, years pass. And then this photograph happens to be about an 8-year follow-up because we tracked this a long time. This was someone we treated back in 2007 or 8. So we take the progress photos. Now, this is someone who never, got that composite. I never put it there. It's not in the smile. So it's one of the ones you get to track over time, and the abfraction doesn't change once the occlusion is vertically loaded. So now the vertical load in the bite prevents further recession and also further abfraction. So this hasn't gotten any worse over time. There's no sensitivity there to hot, cold, sweet, or anything like that. And it's not in the smile line, so the patient doesn't have a cosmetic concern. I get to check it every 6 months when she comes in for recall and know that that abfraction hasn't changed. So it's kind of like a case study in how far can it go? What's the pace of this damage with a good bite? So it turns out if you have a bad bite, the pace is pretty fast because this happens on the left side of the screen rapidly. And then on the right side of the screen, we get to watch it. Now we're over a decade. So pretty nice result. On the left side, it's the same, mouth here, just getting aligned well, and without the collapse of the posterior, you get a nice vertical load in the bite. So what happened here was nice expansion. The posterior teeth are moved out to where they belong, and then the front teeth get a little procline and align. So you move the back teeth out wider, you procline the front teeth, and it allows you to upright all those back teeth. And with all that uprighting comes that beautiful connection. And next thing you know, with that beautiful connection, you get a resolution of the deep bite again. So the posterior teeth are now upright, vertically loaded, which takes the vertical load through the roots into the bone. This patient is set up for success. You have alignment, you've got periodontal gingival improvement, you've got a beautiful protective occlusion again with vertical load, and you're in great shape. Of course, the whitening gel shines up the teeth a little bit and you're in great shape, good looking case. This next one, very significant. Again, these are some of the ones we learn a lot about along the way to see like how capable are clear aligners at delivering all of this expansion and uprighting, which is what we're doing at correcting some of these defects. So we'll take a look at this as a very deep bite with all kinds of trouble. Well, we open that arch up too. So again, a lot of expansion, especially at the canines. So canine back, we open up that arch, the top opens up and then the bottom follows it. Now this nice lady had number 28 tucked in pretty far lingual, also discoloring, so fading, but we were able to expand and upright this whole entire arch without any IPR. So this case is no IPR, probably done around 2008 or 9. So we're over a decade already. And now what we get to see with all that uprighting is a big change. Now, number 28 was tucked all the way underneath, and you could actually see the stain where the CEJ was on 28 and 29. Now that stain line on number 28 is here now. So what you see, number 28 was brought all the way out to the buccal and upright so we can see the entire tooth, and the gum tissue healed. The gum tissue recovered by more than 1 millimeter to now drape itself right across the CEJ. Even tooth number 29, which was starting a cleft in that V-notch cleft, has healed and become a shape that is now kind of normal, and you get a recovery there of about 1 millimeter. And that's with a significant amount of expansion. This is just a reminder how far those teeth moved. Those canines and premolars are much farther apart. This was a significant canine premolar molar expansion case. So again, moving these teeth out all the way. This is about a 28 aligner case. We did 28 aligners. We did 14 months. These were 2 weeks each. One of the important parts about the posterior segment being uprighting when you have recession and or abfraction formation or clefting is that it's not to be rushed. So when we think about a 2-week wear time, it's appropriate. So while there are examples of using 1-week wear time when you have minimal crowding, anterior alignment only, you don't have periodontal concerns, 1 week has a place in aligner therapy, but it's not for the periodontal cases, and it's not for where there's a periodontal concern. In fact, aligners being used at 1 week wear time comes with information, a disclaimer about it, again, dependent upon the doctor's discretion, based on age, based on bone, based on teeth, based on the movement, based on Perio, based on, there was a whole bunch written about that. It's a lot more involved than just you can use them at 1 week. It's not a blanket. So this wouldn't be appropriate. Most of the cases you're going to see are 2-week wear time, but we're looking for an appropriate amount of time for the alveolar tissues to remodel so that we can have healing, not just tooth movement. So what we're looking for is dentoalveolar change, and we're getting dentoalveolar change. So now don't forget how far 28 moved. 28 moved almost an entire tooth. The lingual cusp of 28 gets out past where the buccal started. So we're pretty far out there. We're going to see why in a minute. Because now that tooth comes all the way forward, but look at the indentation in the alveolus here at 28. Now at 28, you see a thickness covering that tooth. Now, again, this is 12, 13 years ago that we did this. You can see the inclination change. The patient happens to be class 2, but that doesn't matter. When you think about the tissue here, most of this recession has a little bit of clefting involved. After we do that significant amount of expansion and uprighting, we convert from horizontal traumatic occlusion, basically horizontally loaded teeth, to vertically loaded teeth, and all the gum tissue heals. On the lower, number 20 has a significant several millimeter long cleft gone. That cleft zips up, and that tissue starts to heal itself into an arch, not a V. Of course, number 21 has a little bit of showing with the CEJ, recovering, but the big one's number 11. Number 11 has a composite marker for us to see where we're starting with the recession and the clefting. Now, the upper arch had significant canine expansion, a significant amount of canine expansion, and sure enough, that gum tissue not only zipped up that cleft, but healed all the way down to that composite marker. This is not a graft. This patient has never had a graft. She's never even been to the periodontist. So in our office, we had some scaling and root plating to start. She went through 28 aligners for 14 months, and this is the end result, which also, by the way, is probably about a 10-year follow-up photograph, because every year we were taking the photos along the way. I've never changed that composite. The craziest thing is that composite still sits there. It's not in the smile line. It's actually like a little inside joke with her that we don't have to change it, and it doesn't show on your smile, and I get to show a marker for the tissue over time. She knows, this is significant. But I want to talk about the dentoalveolar growth. We're talking about bone growth from this photograph. Never mind the deep bite got corrected. Never mind the posterior upright and vertical. Stare at number 28 and the indentation in the bone. On the left side of the screen shows an indentation in the alveolus, and on the right side of the screen shows full alveolar development. That tooth moved, uprighted a whole tooth over to the buccal, and the gum tissue healed. It climbed back up that root more than a millimeter to get to the CEJ, and you have the full dentoalveolar structure. Now, the reason it did that is because one, clear aligners are a removable orthodontic technique. The major difference between braces and aligners is the removable ability. A lot of the myths about expansion, uprighting, tooth movement come from the research on brackets and wires with stainless steel wires, which are totally traumatic and cause a lot of damage. So when you're doing braces, you can't do this because you have something that's fixed. A fixed appliance generates a permanent force that is going towards the buccal, let's say, for expansion. So the reason people say those types of comments are because there's significant amounts of orthodontic research on brackets and wires and canine expansion, all this stuff. But if you're trying to do tooth expansion with braces, it's different than clear aligners. These are two different things. So you don't compare two different things and think you can use the same research from braces on aligners, number one. Number two, it's inappropriate to compare aligners to braces because you have two things that are closer to opposites. So brackets and wires and clear aligners are closer to being opposite than they are the same. And so braces being fixed generate permanent buccal pressure and permanent lingual tension. With the permanent or fixed buccal pressure and lingual tension, you get a tooth moving through the bone, root damage, fenestration, dehiscence. The list of damage that occurs from brackets, wires that are fixed, and stainless steel primarily too. Stainless steel does the most damage because of the highest of forces. That's real. That's all real. That's what happens. That's why the arch wires mostly go straight back now. You look at an arch wire, it's really narrow. So let's distalize, let's retract, let's extract. If we can't go wider without damage to the roots, the gum, the bone, all those things, you look for alternatives, which gives birth to retraction, extraction types of orthodontic techniques, because why cause all the damage going wider? Clear aligners are the opposite of this because they're removable. So the removable technique, you put your aligner in. When your aligners in, the teeth are being moved to the buccal. So you have a pressure on the buccal and a tension on the lingual. But it's interesting what happens when you take your aligner out. Every time you remove your aligner, the teeth are rebounding or relapsing. The teeth start going the other way. Anyone who's worn aligners knows the moment you take your aligner out, the teeth are shifting back the opposite direction. So when your aliner's in, the teeth are moving buccally. So you have pressure on the buccal, tension on the lingual. When you pop your aligner out, the teeth are recovering. Recovering teeth put pressure on the lingual, tension on the buccal. It flips the two. When you flip or cycle pressure and tension, you cause bone growth. That's how bone grows. Bone grows by cycles of pressure and tension. Same thing for tori, etc. So the idea is if you have a removable orthodontic technique, like a clear aligner, you're cycling pressure and tension, not making direct permanent buccal force and lingual tension. So they're two opposite things. The damage occurs with brackets and wires. You have to be very careful with those, which is why most people don't try expansion with braces, because the research is legitimate. Damage the root, damage the gum, damage the bone, push the teeth through the bone, because that is what's happening with braces. Clear aligners don't move teeth through bone. They move teeth with the bone. They generate bone creation. You have bone, depositing. You basically have a removable technique which cycles pressure and tension, and then you get this. This is the picture you get to look at when you widen those arches significantly and you get bone growth around the tooth. Your dentoalveolar structure remodels beautifully and you get to do this. Of course, the deep bite's corrected, the teeth are upright, they're vertical, and 10 years later, the gum tissue's in the same spot, or now 13 actually. So these cases don't.
Let me just back up before we go on to the next case. If you could just go back, there was a question, how old is this patient? Is this mid-40s?
Mid-40s, yeah,
Correct.
mid-40s, and now, oh my goodness, approaching 60. Unbelievable, because this was done in 2008 or so. So you add a 12, 13 years onto that. And yeah, crazy how that time's going by, right? So that patient, mid-40s.
And then another question, could you just quickly explain what clefting is? There are some questions on clefting, maybe just show.
Oh, yeah, I could point right to it. My arrow works on the screen, right?
Yep.
You see my pointer? Yeah,
Yes.
A cleft is, with recession, sometimes there's a cleft. It almost looks like a slice in the gum. In fact, these slices are famously, flossing is famously blamed for that. And when I ask people to floss, they don't put the floss down here. So if ever you see this, try not to blame it on the floss. It's a deterioration from the occlusal trauma. And if you need to prove it to yourself, just ask the patient to floss for you for a second. I don't think people are flossing up here because it's very painful to get floss up here. So you would floss there one time only, and that would be it. So we don't see that because of floss. It's basically this little cleft is a unzipping of the tissue, which is going to lead to big changes down the road, and it heals. All of the right side photograph shows healing without any grafting. No periodontal surgery on any of the patients you're seeing tonight. These are non-surgical cases treated to full resolution, and there you have the dentoalveolar bone growth in that right quadrant. It's really just beautiful what clear aligners are capable of.
Amazing. Great case.
Another patient, another nice young lady, we can call it mid-40s. That's probably about right for guessing the age, but again, completely collapsed arch. And with a completely collapsed arch, anything that has lingual inclination is under horizontal load. We're bending those teeth. With that bending comes big trouble. So we upright them. The posterior segment gets upright. It opens up a lot of space for the crowding to go away without any IPR. And it delivers that, vertical load on the teeth. So we get a resolution of the gum tissue. Here's a very nice after picture of the uprighting in this quadrant. And then of course, it's even more evident on her left side, because on the patient's left side, we had such a collapse in here that the gum tissue was already puffy, a little swollen, 4 or 5 millimeters, a little bleedy. These teeth had large amalgams in them, so they're going to need restorations. But who wants to prepare teeth in this position, right? What if we upright? If you upright the whole segment, look at the healing in the gum tissue. Now the gum tissue is sharp, it's tight, it's got its natural contour, normal anatomy, 3 millimeters at most of pocketing. And next thing you know, you have that vertically loaded occlusion that you could change out those fillings. You want to put new composite, you want to make a crown, you want to make an inlay, an onlay. You don't need crown lengthening over here. All of this tissue healed, and now you have the room to do your restorative dentistry without cutting all this tissue back. Not to mention the fact if you do cut all this back and restore these teeth, those teeth are still under horizontal load. So we just put our dentistry in harm's way. Why not upright those teeth and then restore them later? It's okay to do that. Here they are. So this is that arch. The lower arch completely collapsed. Here it is upright. Not only do you get upright, but look at the rotation on the molars. And that's rotation without attachment. You know, those molars don't have attachments. I don't use molar attachments. The next molar attachment I place will be the first one. So without molar attachments, your aligners can upright, derotate, basically align all these teeth. So there's no IPR for this nice lady. And it takes that horrific arch form that is nothing but occlusal trauma all the way to this, you know, position here. Perfect example of the tori, by the way. Look what the lingual inclination does to bone building. The constant cycle of pressure and tension just from chewing grows that bone. That's incredible. So you want to put a stop to that. You upright those teeth, deliver vertical load, tori stop growing.
And how is an aligner expansion? How is aligner expansion different than expansion with the removable expansion appliance?
Yeah, so if we go to a picture like the upper arch, let me see, did I have it here? I missed it. Oh, I didn't have it in the deck. Yeah, so here's the thing. With clear aligners, you're in the dentoalveolar category. So we're getting dentoalveolar change and expansion like we're watching here. With a removable expansion device for adults, then you're getting sutural change. And so when we need someone's maxilla to grow a lot, past what dentoalveolar would do, we use a removable expansion appliance first. A removable expansion appliance worn accordingly can give you sutural changes throughout the maxilla. And not only do we do that, we also teach it and we publish it. And so we've got a couple of cases of that published and we teach that quite a bit. It would be well beyond, I think we had a whole meeting on that once. We might need to repeat that one if that question keeps popping up.
Actually, so you can go back into our podcasts on our removable expander section with adults on www.airwayhealthsolutions.com/podcast. So thank you.
Yes, that's out there for you to see more of. So sometimes we use, now if we use those first, it's aligners after it, because that's a foundational appliance. A removable upper expansion appliance sets the stage for then aligners to finish with the dentoalveolar. This is a nice one. Pre-restorative, you know, the patient needed a whole bunch of new crowns done on all these teeth, but when she comes in looking like this, you know, of course, we're going to find a lot of perio issues, you know, with recession, with pocking, with bleeding, with all this abfraction. Here we have composites that were placed. They're all failing. It's almost like a stage of failing, mild, moderate, severe. That one popped out. The lower one popped out. So you have, over time, you put those composites in. And of course, if the teeth are in occlusal trauma, this is exactly what happens. You start finding the margin, the abfraction continues. Eventually it pops out. We get to repeat it. How about we just change the bite first? So aligners first, restorative second. And again, no periodontal surgery here. We haven't done any crown lengthening, no laser, no scalpel, no electrosurge, nothing other than hand scaling and root planings are done on these patients. So, and then of course, 6-month maintenance scalings. So with scaling only, and then of course, alignment, we're going to do that expansion with alignment. Then we're going to make new crowns for this nice lady, tissue level, all ceramic tissue level. And then we get this beautiful gum tissue. It totally heals. I mean, the tissue from in between all of these teeth before, where we have the abfractions and every stage of abfraction being repaired over time, and then new lesions starting again, just kind of failing, not treating the cause, treating the symptom there. So this one here, we had the lower front teeth had some bone loss. So we elected to put in a lingual bar here just for a little more stability. That I do use on patients who have some bone loss in the lower anterior. I like a little lingual splint for some people, make sure they're secure. That's totally fine. We still give a clear aligner for retainer afterwards. But when the top is done with its expansion and alignment, we can make the set of crowns going one side to the other. So basically 3 to 14, and then the lower posteriors are done. And next thing you know, you got a nice comprehensive case. And thanks to the aligners setting up the occlusion to be healthy, not traumatic, the patient doesn't need to have crown lengthenings and all the other stuff. The pockets, you know, disappear. We're 3 and under everywhere. There's no probing, no bleeding. And then the bonus is we get to see that gum line without any types of surgery. The marks at the front were from apicoectomies that she had way back when. These 2 teeth here, there was a nice apicoectomy done. So since it was healthy, we kept that tooth. You know, we weren't going to take that out. But then we have 5-year follow-ups. Yeah, there we go. Mm-hmm. So this is 5 years later. Now, 5 years later, the tissue hasn't changed. It's gone nowhere. So we have this healthy gum line that's in exactly the same place that we left it. And it's a first 5 years. So here you have 5 years later showing beautifully healthy tissue. The patient comes in every 6 months, gets their teeth scaled, has a nice polish, then we leave them alone. So we get another one.
Good question.
Yes.
Will posterior proximal contacts open or occlusal contacts open with expansion techniques?
Occlusal contacts, no, those improve. So the idea behind having a deep bite is that once you address the back teeth and you upright them, you're making the back teeth closer together. See, when the lower teeth are leaning in and you upright them, you're elevating the occlusal surface. So this is called relative extrusion. So uprighting the back teeth brings the occlusal plane higher. Now on the top teeth that are angled in, we're uprighting them, but it's kind of swinging them down. So, I'm trying to do the top teeth here. Let's try it like that. The top teeth are like this. I'm going to have a broken wrist. The top teeth are like this. We go like that. That lowers them. So you're swinging them down. So that lowers them. The bottom teeth are coming up. Basically what's happening in the back, those teeth are getting closer together. So you could only have more contact in the back, not less. The trouble with the posterior open bite, which I think that question was alluding to, the trouble with occlusal contacts being light is when you're starting with a deep bite. If you're working on a deep bite and you have the back collapsed and you don't address the posterior, the moment you have any type of interference contact in the front, you're going to separate the back teeth. So posterior open bite really isn't posterior open bite, it's anterior premature contact. Anterior premature contact causes posterior open bite. So the anterior premature contact comes from a lack of posterior expansion or uprighting. You haven't tried to work on the back teeth, especially the molars, but you're trying to fight the deep bite, and that usually comes from excess intrusion. But you've got crowding. So you're trying to intrude crowded teeth and you're spreading them out. And what happens is they start touching. So the unraveling of the crowding does happen, but the intrusion doesn't always happen. Now, if the intrusion doesn't happen, but the crowding's getting unraveled, these teeth touch first and the back teeth don't meet. Basically, the posterior open bite comes from crowding being successfully resolved, but intrusion not being successfully resolved. And then the front teeth are unraveled, but touching first and the back teeth don't meet. So next thing you know, you see posterior. Now, interproximal contacts was brought up. The fascinating thing is that these people are crowded. When you have crowding and posterior collapse, your uprighting of the posterior teeth doesn't open up those contacts. What it does is it delivers the space to unravel the front teeth. So you're unraveling the arch and getting rid of the crowding by uprighting the posterior teeth. Basically what you're doing is you're putting the teeth where they belong. No one's teeth belong crowded and no one's teeth belong with lingual inclination. So a human being should have 32 teeth, all of them fully upright in a beautiful, broad, wide arch. That's what it means to be human. So we're only moving teeth where they belong, which is why you get healing if you do it with a removable technique. If you try it with a fixed technique, you get damage. That's what fixed does.
We have a couple of non-dental guests on tonight from our medical colleagues as well.
Sure.
Can you just quickly explain IPR so people understand?
Oh yeah, so I brushed over that. IPR is interproximal reduction. Interproximal reduction. It's a way to polish in between teeth to make room. So what happens with IPR is you take a finishing strip, it's like a metal polishing strip, and you pass it between teeth. It's abrasive flossing at its easiest. Or you could take a disc or a burr and cut between the teeth. If you cut between teeth, you have room to unravel them, but I don't do that anymore. That was then. So I use very little to no IPR now. The idea was at the beginning, I was taught that technique, and now I recognize that there's a difference between needing it and using it. So interproximal reduction can help get rid of crowding, but it's not meant to develop the perfect occlusion. You got to move all the teeth for that. Oh, then we meet this nice lady. So she comes in, she's wearing an upper partial. The lower four incisors are hypermobile, uncomfortable, can't really chew or use them anymore. She came in with a chief complaint of, these teeth are bothering me so much, I am ready to extract them and get my partial on the bottom. She was ready to accept a lower partial. Now, this happens to be a long time ago. We'll show you where we're going here, but aligner 14, because we talked her all the way through consultation. We need to move your teeth back where they belong, give you a good bite. If we can solve your traumatic occlusion here and get your tongue basically cooperating as well, meaning staying in the palate and behind the teeth, we'll be in great shape. So we bring these teeth back to where they belong. Aligner 14, we're making progress. Aligner 18, more progress. So basically we get her all the way here, 23 aligners, do a little bit of refinement after that. So I'm guessing I probably used about 30 aligners for this case. And then we get to the final aligner and we're here. So we have these teeth well aligned, and this is the before and after. Now, her teeth had spread out so far that she had room to add teeth. And if you think about losing those four incisors, what am I going to make there? The partial would have like 7 incisors across there, but it would be in a class 3 with the upper. How am I going to build the upper that far out? Her tongue had driven this so far forward. So we brought it back to where it belonged. We put the little splint there. The teeth started out with better than 2+ mobility at the beginning. She was ready to lose them. This is also about 15 years ago, I think I treated her.
Yeah.
So now we put these teeth where they belong. We do this. I make her a new upper partial. And next thing you know, time goes by. So with the brand new partial, a beautiful bite, the gum and the bone is totally, safe, sound. The teeth tighten up. I have the little splint there, but we take x-rays along the way. This was probably like a 10-year x-ray follow-up. This nice lady was in last month for recall. So I get to see her every 6 months. She comes in for a recall. We clean her teeth. How do they feel? Totally comfortable. Solid. I can touch them. They're not moving. She still has them today. So we've gone at least 12 years. It might be 15. I have to look it up now. So better than a decade with these teeth, and she was ready to take them out and make a partial. Someone who doesn't have a clear aligner technique maybe would have done that for her, and that would have been a disaster trying to work with those canines where they were separated by like 2 zip codes. So that's a nice case.
Couple questions on that. Did she have myofunctional therapy, and was a tongue tie addressed?
Yeah, a little bit. So the tongue tie was not addressed, but the myofunctional therapy was I was doing some exercises in the office at the time, very few, but only enough just to get the tongue in the roof of the mouth. So yeah, with myofunctional therapy, I'm playing checkers. I know that whole world is chess. I send it all out now. So I've learned my lesson over time. Yeah, I send that to an orofacial myofunctional therapist, and that patient has to go every day of the week because we don't get to keep that result without getting the tongue to be appropriate and cooperative. So while it's in the right place now, it hasn't changed over the dozen or 15 years. I'd have to look it up, but the reason is her tongue is now in the roof of her mouth. Never did the frenectomy. At the time, I wasn't into it, but now I know differently. Turns out most people need the frenectomy, and you learn that over time too. So I'm catching up.
Great, thank you.
Now another one, just to take it a step further. This patient is referred by our local periodontist. Dr. Victor Sternberg is an exceptional periodontist in Westchester County, New York. And so he refers this patient to me to consider planning an implant reconstruction because of what's happening, a lot of damage. So we meet this patient who happens to be 46 years old at the time, very young. This patient had 4 bicuspids extracted, 4 years in braces that were incredibly tight and painful. And the patient, with her own words, says, the damage to my mouth began with the braces and the extractions, because she watched her gum tissue disappear during the time she was having braces. By the time she was 18, she had most of this recession. 18 to 46, she's been doing periodontal maintenance for 3-month intervals all the way through just to maintain the level that she has, but she recognizes all the damage was caused in those years. So here we are at 46, and the lower front teeth have very little bone in there. So we're collapsed, we're missing the bis, the history is all there. And of course, collapsed means expansion. The molars all have furcation involvement. The lower front teeth have very little bone, which we're going to see in a second. About a couple millimeters are in there. So we've got furcation involvement. Clean. She's very clean. She's meticulous. Hygiene is not the issue. There is occlusal trauma over time, but the patient, knowing her history, knows that most of this recession was present by the time she was 18, thanks to the trauma that she had gone through with brackets, wires, and extractions. So what a nightmare to be at 46 now. And at 46, the periodontist is saying, the lower front teeth are going to go first. It's going to be like dominoes. Your furcations are going to be second. You need to be somewhere where you can plan an implant reconstructive process, because you're going to end up with 6 to 8 implants in each arch and a beautiful, restored mouth as your 3rd set of teeth coming your way. So she ends up, we meet her. Of course, you know what we're going to do. I'm going to put her in aligners. The picture got grainy, but you can still see where the bone is or isn't. So here you got a couple of millimeters of bone left in those incisors and a bunch of composites holding them in. So you could imagine the mobility that was done for this case. Now, fantastic thing about this is I treated this patient 8 years ago. So we're 8 years later, she hasn't lost a single tooth. This happens to be aligner number 1. I had to take all of that composite off of these teeth to get an accurate impression at the time. Now, 8 years ago, yes, forgive me, I was taking an impression, not a scan. So it would have been great to have a scanner 8 years ago. I did not have one 8 years ago. My bad. I took an impression. Now, the way I did that was, I was trying to be clever, but I wanted it as accurate as possible. I wanted all that composite out of there. I took out the composite. I took an alginate because it's forgiving. I took an alginate, then poured it in stone, then PVS'd it, then sent it in for the aligners, and walked this patient through 24 aligners, so 12 months. Again, 2 weeks each. So she wore them all the time. She took them out to eat, clean, and, change her things. She protected her front teeth because they were hypermobile. So she did not chew with her front teeth. She didn't tear anything. This was going to be a real soft, protective diet. She was able to do it. So she knew how they felt. Even brushing them, she knew how they felt. So she did a perfect job of protecting those teeth all the way through. Same pathway, expand. expand and procline. The teeth are moving away to, shape the arch, get rid of the resulting crowding from her collapse. And of course, after we move these teeth out where they belong and upright them all, I did put a lingual bar with the composite. So I have a lingual bar with the composite as a periodontal splint, we could call it. But the idea there is we were able to go before and after. And so I've got her in a spot where the occlusion is no longer traumatic on the incisors. That's helpful. We did clear aligners for 12 months. Now, this is even better news. This x-ray is taken on the last aligner. So she wore 24 aligners. This is an x-ray taken, I wore 24 aligners. The day we put the lingual bar on, I took that x-ray. So this is 24th aligner just worn for 2 weeks. That's with the movement during that. It's not 3 months healing. It's not 6 months healing. It's not 5 years later. This is the bone growth that occurs with cycles of pressure and tension. Now, braces would have extracted those teeth. No one in their right mind would put braces on those teeth unless they were planning to take them out and restore with implants immediately. So we took her through 12 months of tooth movement with clear aligners, removable technique, and grew that bone. So even the periodontist who, allowed me to go forward with this case, even though I had to twist his arm a little bit, said, I can't believe what you did to that bone with clear aligners. I've seen braces damage everything they touch, but this is unbelievable. Now, here we are 8 years later. 8 years later, this lady has not lost a single tooth. She has no mobility, no discomfort, no anything. She kind of eats and bites normally and chews perfectly fine. You add 46 and 8, you're up to 54. So imagine being 46 and getting prepared for losing every tooth in your head for an implant reconstruction, the whole psychology behind all of that. Here she is at 54, and she has however many millimeters this is, but bone growth. You grow bone when you cycle pressure and tension. You don't cause damage. So that's about as severe a case as I've ever treated, molarifications, 2 millimeters of bone in the anterior. But when a more severe one comes around, I'll treat it and I'll share it. I'm happy to do that.
Wonderful cases. And maybe just keep the screen up just in case we have some questions regarding the cases. One was
sure.
Dr. Rocker is saying that some dentists are having patients keep aligners in to eat and drink during treatment, never taking out except brushing. What do you think about that?
Yeah, so I'm not a fan of approaching 24-hour wear time. And so when you take a clear aligner and you wear it for 24 hours, you now have a fixed orthodontic technique. You're going to approach the braces mode. So wearing them through meals isn't for me. I like them out, and I actually ask my patients for 20 hours a day. And I know some where it's written 20 to 22, whatever. I ask for 20 because they probably give me 16, 18 to 20, somewhere like that. 20 hours a day means sleep with it. And then during the day, enjoy your meals, enjoy your coffee, enjoy your break, have a whatever. If you can take it out for 4 hours, usually it's spread out, because if it's spread out during the day, you're adding cycles of pressure and tension. It's better if you pop them off and let those teeth recover. Allow the relapse to happen in between the change. Take them out, use them, chew with them, let them relapse a little, put them back in. So aligners in and out is important. Wearing them, through all of the meals makes it more of a 22, 23, 24 hour a day. Now you don't allow for relapse. You're going to shift your pressure tension theory to absolute. Absolute pressure tension is 6 braces. That's 24 hours a day. You want cycles of pressure and tension. So a clear aligner, removable, it has an advantage of lowest force possible. So brackets and wires are well above the force threshold of clear aligners. That's a big difference. It's a multiple. So you have the low force, but you want the cycles, which means on and off. The only time I would consider eating it in a meal is a patient like this, where those teeth, if she were to bite an apple or something even a little bit more, less than that, it could pull those teeth right out. I would say, look, if you wanted to eat something harder, leave that lower aligner in and go ahead and bite something. But meanwhile, we talked her through eating softer and eating easier, but turns out we didn't have to do much, because guess what you're doing when you have this to begin with? She's not challenging those teeth. She's known for a long time, since she's 18, these teeth are in trouble. They're bonded together. She's going to the periodontist. She's never bitten anything on these teeth to begin with, so we're not even asking for a big change. Yeah, but if she wanted to chew something a little harder, I'd say, okay, wear that during a meal. Mostly, no, don't wear them during a meal. You want to boost your game a little further, get yourself a V-Pro device, because a pulsation device can stimulate things. So you have your aligners in. If you're trying to, have more time, not necessarily the answer, get V-Pro. You do 5 minutes a day. Pulsation stimulates blood flow. And there you have a better healing process going, but you get your aligners out is more important for healing.
So I keep getting these questions about, so then we should not worry about moving teeth that have mobility. How would you respond to that?
Well, the teeth that have mobility at the beginning, their chances are under occlusal trauma at the time, or already have a level of gum and bone loss where they're not held in as much. So the moment I meet teeth that are mobile, I want aligners on them because I need to correct the occlusion. So I meet mobile teeth, I start talking about fixing the bite. And so mobile teeth are mobile, and I'm going to say primarily because of the malocclusion. And then secondarily, you can throw in hygiene, you can throw in diet, you can throw in the list. Maybe the patient hasn't gone to the dentist in 10 years. Like, yes, there's a long list, but when I meet mobile teeth, they're usually attached to a terrible malocclusion. So I want to correct the malocclusion. The fastest way to help a mobile tooth is get it in a better bite. What do we do for mobile teeth to make an instant correction? We equilibrate it, take it out of contact, do an equilibration, polish away, take it. Okay, well, taking it out of contact, and guess what happens? It starts shifting, it gets contact again. How many times are we going to equilibrate this poor tooth? How about we move them? If you move the teeth and you deliver vertical load, that mobile tooth isn't going to be in trouble while using clear aligners, because clear aligners are going to give you your cycles of pressure and tension to help you with the bone, dental-alveolar change. And if it is missing a significant amount of bone, the mobility at the very end of the case could only be the same or better. It can't be worse, same or better. Now, at the end of the case with clear aligners, that tooth will probably have more mobility because you just generated all the histology. Tooth movement with good histology comes with decreased bone density and more mobility. During treatment, mobility is fabulous, because if you've got significant mobility during treatment, you're doing a great job. If you don't have mobility, but the teeth are going, you're damaging. So you're looking for nice mobility during. It does take 6 months after treatment for all the mobility to go away. So when you get the case finished, you wear your retainers full time in these perio cases for 6 months, let all the bone get its density back, heal, and then you have everything as tight as it could possibly be. But again, mobile teeth need treatment, and treatment means movement for better occlusion.
Perfect. Do you have evidence of repairing fenestrations?
Evidence of repairing fenestrations? No, I don't have evidence repairing. No, I have evidence of never causing one, that's for sure. 18 years of never having. Yeah, I don't have root damage, I don't have gum damage, I don't have bone damage, I don't have recession, I don't have tooth coming through the bone, you know, all these things you hear about. That's a scare tactic for when brackets and wires are used with stainless steel. You know, it's a method to keep a GP out of ortho. And sometimes that's used to say like, oh, you're going to move teeth through the bone, you're going to get in trouble, don't get in trouble, you don't know what you're doing. You know, and there was a time where I was afraid of those things till I realized, wait a second, I didn't even know bone dynamics. Now I know bone dynamics. Now I know removable. Now I know cycles. And you put this together over a long period of time, and it turns out people who have loose teeth and recession and bone loss and all this stuff, they need their occlusion fixed by tooth movement. Tooth movement is really the only thing that converts horizontally loaded occlusal trauma to vertical load. So yeah, I'm not afraid of moving the teeth anymore. And the good news is we have clear aligners to do it. Adults should not have braces at all. Too harmful for adults.
What is the purpose of a periodontal splint, and is often permanent?
Oh, well, this here, the lingual bar I would call it a lingual bar if I'm talking ortho. If I'm talking perio, I call it a periodontal splint. And so this one lingual bar serves the same purpose because these teeth are too mobile and have no support to be left on their own. So they're strength in numbers. This is a canine to canine, 22, 23, 24, 25, 26. Each tooth is bonded to that nice little bar. That bar is, of course, a lingual bar in the orthodontic world, but it is a periodontal splint. It's extra coronal. I don't cut grooves in the teeth. I just lay it across the teeth, etch and bond, flowable right across the top of it, and it makes for a very nice periodontal splint. So you link these teeth together, and next thing you know, 8 years goes by, and you're still enjoying all that millimeter of bone growth there with no damage, no change, no discomfort. I don't even have a prediction when she'll lose those now. Now that I've seen 8 years of this, I'm thinking to myself, I'm going to watch this go another decade. There's no reason why anything should fail here. So yeah, a lingual bar is a nice choice to use, but guess what? We still wear the clear retainer over it at night because the lingual bar controls 22 to 27. But when you're moving all of the teeth to change the occlusion, in her case, she only had 24 of them. But when you're moving 24, that's only 6 out of 24 being locked in with retention. So you're still going to wear an upper and lower clear retainer over that bar for every nighttime. And that's the routine for all these patients. They all have a clear retainer all night long.
And why don't you use attachments on molars?
Oh, so, you know, I was doing Invisalign, I think, for 7 or 8 years before they existed. And so in 7 or 8 years, I had done almost everything you could imagine without a molar attachment. So when they came into existence and were available, I just went with straightforward common sense and said, well, I haven't used them yet. Why do I want to add that to my technique? The patients don't enjoy all those attachments on their teeth. Why am I adding more? I was looking at the time, since it was, a good 8 or 10 years later, I was actually looking to use less. And so I was starting to minimize my attachments as much as possible and start picking some away from the case. Why would I be adding? Number one. Number two, I didn't want to bond back there either, because now I got to isolate the molar. I got to get it clean. I got to get it bonded on. So I have these reasons at the time, hundreds and hundreds of cases without a molar attachment, wildly successful. I've been publishing and writing and teaching since I started this. So I didn't have a need for it. I didn't want to add it to the case. I was heading in the other direction of using less. So here I am. And I think the molar attachments have been available since maybe 2010, 11, or 12. So believe it or not, it's going on a decade that they've been available, and I still haven't put one on. So I had almost 8 years without them. Common sense said, well, I didn't need them yet. Why add? I didn't put them on the cases. We'll never put them on the cases now that 10 years are going by and I still don't need them. So they're just not for me. I don't believe I need them.
Do you see root resorption from past ortho healing? Do you ever see healing from that?
Root resorption. No, I don't see teeth get longer.
Okay.
Yeah, and we get a fair amount of adults who come in who have that, ortho blunting or root resorption. And, again, if you get an adult that has the shorter roots, of course, you want to correct the malocclusion, because the traumatic occlusion isn't helping those teeth, because now they have a shorter space for gum and bone to hold those teeth for the decades. So if you want to do orthodontics on someone who had shortened roots from previous brackets and wires as a teenager, clear aligners are the answer. And again, all of the cases you watched were 2-week intervals. These are not patients, when you're thinking about molar movement, uprighting the posterior significantly like you saw, periodontal concerns, buccal recession and abfraction, which we expand or upright into, of course, clefting and you've seen all the movement out to the buccal and healing. It's not a 1-week wear time for this. That's too aggressive. When you're doing 1-week changes, you're making that force get higher and higher and higher. And if the remodeling can't keep up with the force, you see damage. So do I have people who say, I'm getting recession in the buccal? The first question I ask is, are you doing 1 week? Go back to 2. And they say, oh no, I was. Yeah, well, read the whole thing about 1 week. It has a place. I'm not here to say 1 week's bad. That's not appropriate. 1 week is wonderful wear time for the right cases. So you have younger patients with no history of gum and bone change. You want to do 1 week, you do an anterior alignment. There's a long list of people who could do that. But when you're dealing with the adults who have histories in perio, recession, abfraction, some clefting, bone loss, things like this, mobile teeth at the start, you want the 2 weeks because you're looking for the histology to keep up with the cycles of pressure and tension and maintain a low force level. The 1 week can ratchet up the force level and it can move the teeth. I know that. I know 1 week works. You can move the teeth, but are you exchanging damage for it? So be careful in this category. That's what part of the thing was about considering the patient age, the bone quality, the bone levels, the change of the occlusion, the tooth movements. There's a list of things that go into considering the 1 week. Read the whole paragraph. And then once you understand the whole paragraph, you make good choices. You do 1 week where it's indicated. You do 2 weeks where it's indicated. Why not win in every category?
And how about if they have an anterior crossbite? Isn't it hard to jump the crossbite when they take them out 4 hours a day?
Amazingly, not at all. So here I am, I think it's my 17th or 18th year doing Invisalign. I don't have a single anterior tooth that didn't correct a crossbite, and almost always in the first round of aligners. And so you could talk about central incisors, you could talk about laterals, you could talk about canines. I'm calling the anterior teeth canine to canine. So any individual tooth in the anterior in crossbite, aligners alone will correct it. What's happening is, of course, the moment the tooth in crossbite, I don't know, I'm doing this all wrong maybe, but of course the tooth in crossbite has to jump over. So the teeth don't move up, over, and down. They just go straight through. So what happens is we just tell the patient, listen, as we're moving your teeth, these two are going to bump into each other. So you're going to be careful when you're chewing, because there's a phase where you feel weird, like that tooth is touching, but then it goes over and it feels fine. So clear aligners have disclusion built into it because they go in and you have the separation while they're in. When you take them out, enjoy your meals. Of course, the crossbite people have to be told, it'll bump a little bit there. Be careful, don't crash on your tooth. Go a little easier. It's the middle months. See, in the beginning, you're in crossbite, your teeth fit together, you're fine. The middle months, it's weird, it's hitting, but then after it jumps over, you're back to normal again. So they just have to pay attention. Now, of course, those patients want that fixed because an anterior tooth in crossbite does not look good. They're in it for the aesthetics. We're in it for the occlusion. But they know how that's going to look afterwards because you showed them the video and you got this beautiful bite afterwards. So this is what we're going to look like soon. All you got to do is survive this one phase in the middle where your bite's going to feel real strange. When your bite feels strange, go easy. Let's not try to break your teeth while we're moving them, and you can have your funny exchange with them a little bit. And if they agree that, okay, I can do this during that period of time, I know it's coming, great. If you didn't share that with the patient, of course, 3 months later, they're going to say, you know, when I bite down, these teeth really hit hard and it hurts me. If you talk about it first, it's easy to get through. But you don't need to wear your aligners 24 hours a day for an anterior crossbite. I'll go one step further. Premolars do the same correction. Premolars can correct a premolar crossbite. Doesn't matter if it's 1 or 2 or more. Premolar crossbites correct with aligners alone without having to wear them extra long. You're going to get premolar. It's the molar crossbite that is just totally opposite. The molar crossbites are resistant. They do fight. Believe me, I have tried. I would love nothing more than to correct molar crossbite with aligners alone, but I have tried on the patients who were agreeable, which is many over the years. I've tried every which way to get clear aligners to correct a molar crossbite successfully and fully, but it doesn't work for me. I take molar crossbites into removable adult expansion appliances first, grow the foundation, get into aligners, finish up that way. That's better for me that way.
A question we had is, what expansion appliances do you use for that?
Well, it's hard to describe it. It's a removable, but you know, it'll have acrylic, it'll have a little bit of metal, it's going to have a center mechanism to turn it. You know, there are a lot of them out there. I've tried most of them. You know, you could do anything from a generic Schwartz appliance to grow the maxilla, all the way to the DNA appliances that exist from Dr. Singh. I learned from him a long time ago. So you have any number of ways to learn that technique, but it takes learning that technique. It's not just ordering one.
And will expansion cause buccal gingival recession in someone with a thin gingival biotype? Like Hillary was pretty thin, so.
Oh yeah. Yeah, most of these patients would be classified as thin because when you have recession and clefting and things like this, you're called thin biotype. But the idea is, repeat that question, the beginning part. Will it cause it?
Sure. Will expansion cause buccal gingival recession in someone with a thin gingival biotype?
It will if you put on braces. If you put on brackets and wires, yes, because you have a fixed force that's too high, which is why brackets and wires are now designed to stay narrow. Maintain the lingual inclination, which is excessive. Try to align the front teeth. It's by distalization or retraction or extraction. And then if you want to heal or improve the buccal condition, you can use clear aligners with a removable technique. Removable technique is what saves the day. And it doesn't matter if they have a thin biotype or not, because you're getting dentoalveolar change. And the one patient with the caved in number 28 with the defect in the alveolar housing, which I could go right back to that case real quick and put that picture up, because if that's not thin, it's not thin, it's missing. That's a missing biotype. We could have a new category to define that nice lady. But let me bring up that buccal position there because that's like totally crazy. Here it is. This is the indentation at the position of number 28. The entire alveolus is caved in. So I would say worse than thin. And here it is after all that uprighting. Now, how much did it move? Let's get this is how far they moved. This is how much of that change happened with aligners alone. Look at the canine expansion. The canine expansion significant. The premolar expansion significant. The molars are fully upright. And what happens to the buccal bone? It heals. So yeah, you can't push teeth through the bone with clear aligners unless you're going to force a 7-day change. It's too quickly happening. You can't have the histology keep up with you. So I would never approach these types of cases with 7-day change, 2 weeks each. And then of course, 20 hours a day, because you're looking for time out and you just don't do 4 in a row. Nobody takes them out for 4 hours straight. It's a breakfast, a coffee, a lunch, a dinner, a snack, a dessert, wine, whatever it is. You got it spread out. When the 4 hours is spread out, it makes for more cycles. The more cycles, the better. Then you get bone growth.
I keep getting this question even now. It basically says, is he saying that we can just do expansion with aligners alone? Is that what we're saying?
Well, this is what you're looking at. You're looking at expansion. Yeah. The word expansion, it doesn't mean sutural. I thought I made it clear earlier, but clear aligners are dentoalveolar change. Dental alveolar, teeth and alveolus are what are moving here. This is not a sutural product. If we get into the whole conversation of removable adult expansion devices, which we cover in a separate session, which should be archived to look at, right? Removable appliances in adults create sutural change. There's research on that. Dr. Singh and everybody else like him shows all that volumetric increase in the maxilla, sutural change, nasal cavity change, all that stuff is out there to learn. But the idea is, this is dentoalveolar. So the word expansion, when I use the word expansion, it means uprighting in these cases, because the back teeth are uprighting. I'm not expanding the suture. I'm expanding the arches. So dentoalveolar change with aligners, very capable because they're not fixed. Brackets and wires and aligners are closer to being opposites than they are. They have very few similarities. They're both used to move teeth around, but clear aligners and braces are not to be compared, especially clear aligners should never be compared or thought of in the same light as the research that exists on brackets, wires, and stainless steel activity. That's meant for brackets, wires, and stainless steel. You don't read that and say, oh, that applies to clear aligners too. No, no, no. These are opposites when it comes to pressure tension theory, forces, etc.
Well, I can't thank you enough for clarifying, for busting these myths, for showing and telling with your research and the 15-year follow-up and still going strong. It's really amazing. In fact, when I first saw Evan, I was in a CE course, and it just completely changed my whole dental world. And here I am now with you at Airway Health Solutions, sharing all these stories, 11 years later or so. So thanks again for all your hard work and your dedication to making orthodontics a healthy choice for your patients. I am just going to go ahead and give some updates with some.
Oh yeah, should I stop sharing for you?
It's okay. I think I can do it actually.
You got it.
Let me just show all my windows here. Okay, hold on. Great. There we go. I think you can see my screen. We have some other upcoming conversations as well, but let me go to the beginning here. So we had so many questions on the techniques of how to do this. And I wish we had a magic wand and we could just tell everyone how you did this in 30 seconds or less, but that's why we created our mini residency, which is a 10-hour course on how to do this. And we have a couple of spots open for Friday for our adult mini residency. And that's where we focus on removable expansion appliances and also clear aligner therapy to do the expansion. So we do offer these monthly with the exception of August and December. So please check out our website to learn more about that. We also offer a myofunctional course specifically for the RDH. Dentists are welcome as well, but it's really focusing on integrating myo into the dental practice. So we're really proud of this course with Brittany Sierra and Carice Laguerre. So again, check out our website for that. And specifically, we have a lot of interest in clear aligners tonight. So we do have a clear aligner case review. It's kind of more like a workshop style where we're just going to be doing case reviews one after the other. So that's going to be June 3rd. It's a Thursday evening from 7 to 10. You can sign up as either a case submitter or an auditor. So please, you'll learn a lot. Whatever aligner system you use, you can apply it to any system. So hopefully you can learn a little bit more about Dr. Miraglia's techniques from taking that course. So stay tuned for that. Please follow us on social media. You can also follow my expansion blog. I'm going to be transitioning to clear aligners, sometime in the near future, hopefully after I get more of the expansion I want with my removable expansion appliance from Kevin Ohlendorf. We're kind of winding down our schedule. We're going to take a little break over the summer, but I'm excited that in a couple of weeks we have Professor John Yu, and he'll be on with us. It's a Friday at noon due to the time changes. We have Dr. Lauren Ballinger on May 19th. She's a pediatric dentist who just does airway all day, every day. She's a completely airway-centric practice. Dr. Richard Downs will be joining us if you want to add sleep to your airway practice, so easy steps on how to do that. And then we're going to take a little hiatus and enjoy some of these New York and Connecticut summer nights by us. We do have airway dentists, so if you're looking for an airway dentist, please go to airwayhealthsolutions.com/locator, and then you can put in your zip code and find an airway dentist near you. And if you are a dentist, we would love to feature you on this so other patients can get your help to help them breathe, sleep, and thrive as well. So here's my contact information. I think everybody has it just from all of the invitations, but please feel free to reach out with any questions you may have. I know a lot of the questions, again, we had 200 of them, were answered with the case reviews. So if we have more interest, we can always do a part 2, because we're here if you need us, and we're really excited that you're joining us weekly. We have a lot of I'm going to say, loyal listeners who attend all of our Airway Health Solutions conversations. So thank you for that. And you can always watch our archives on our website as well. So thanks again, Dr. Miraglia. Any closing thoughts or advice you have for any of our listeners? Besides take our mini residency?
It was my pleasure. And, you know, we're always looking to teach more. If you want to see this over a course of a day, we can teach you how to do this, because everybody should be enjoying those types of results with their clear aligner technique.
Terrific. All right. Well, thanks everyone for your attention, and we'll see you next time with Dr. Mew. Have a great night.
Good night, everyone.